going to be talking a little bit about practical strategies and tips, hopefully focusing on some real world things that you can implement in primary care, some things that I tell my patients. I have no relevant disclosures. And I want to start off by emphasizing the 2025 American Diabetes Association guidelines on MASLD and MASH, where the foundation really is lifestyle. I want to really emphasize that. And as Carrie just mentioned, 5% weight reduction is one of the thresholds we say in terms of reducing steatosis, and 7 to 10% being that threshold to reverse steatohepatitis and liver fibrosis. But that is innately tied to all of these other things, right? You can't accomplish this weight loss without the behavioral health component, the alcohol reduction, the exercise, which we'll hear about, and then I will focus on this nutrition component. I have to start off by emphasizing that there are principles of effective nutrition counseling, right? Something that I've fallen, unfortunately, into a habit to, or was trained to do, right, was to say we should do 150 minutes of aerobic exercise a week, right? That's what the guidelines say. But that's not a SMART goal. That's not a specific, measurable, attainable goal for the vast majority of our patients. And in fact, I like to use the acronym SIMPLE, so sustainable, implementable, measurable, practical, and easy, with an emphasis on the practical and the easy. So for example, I frequently tell my patients, why don't you just start off by taking a brisk walk around your neighborhood for 30 minutes, 3 days a week. After a few weeks, maybe try going for 4 days a week. After a few weeks of doing that, maybe start incorporating some resistance at home 1 day a week, right? So it's baby steps. The second thing I want to mention is that MASLD really does tend to cluster in families, and this is a point I think that hasn't been brought up yet, but because of that, it's really important to actually, involve the family and counsel the family as well if you want to improve adherence and improve outcomes. Of course, we also need to take into account our patients' work schedules, their cultural traditions, and then their financial realities. Now, in terms of are there actual nutrition guidelines for MASLD, there are many society-based recommendations, but I really want to highlight this article that actually just came out this past week, a few days ago, that I have taken and used a lot of it for my presentation, and Dr. Jonathan Stein is actually a co-author on this. I highly recommend that you read this, but I will definitely give you some of the highlights. So first, in terms of micro and macronutrients, there's really no one size fits all. In other words, the evidence really doesn't show that there's an ideal carb to fat to protein ratio when it comes to MASLD and MASH. With that being said, some of the things that I still hammer home in terms of macronutrients is the dietary fiber component. This article mentions 30 grams a day, which is definitely easier to remember, but I also emphasize 28 for women and 35 for men in my patients. I also think product examples are probably the best thing we can do for our patients, right? They're going to know what hazelnuts and sesame seeds are and avocado, but they're not going to know what a monounsaturated fat is, right? So really making it easier for our patients to understand. There's also some evidence that some micronutrients like vitamin C, vitamin E, and polyphenols have some benefit in MASLD, specifically vitamin E. In the Pivens trial, which I won't get into today, did show that 800 units of vitamin E improved histology in non-diabetic MASH, so in patients with MASH without diabetes. But what should our patients really try to avoid? And I really like this diagram that they put in their paper. So starting off with this pale yellow component of the circle here, sugar-sweetened beverages, which Mark brought up earlier, which I think is incredibly important. Multiple studies have shown this again and again, that there are large increases in intrahepatic lipid content when you compare patients that consume SSBs versus those that don't. In fact, their odds ratio of MASLD is 2.53 compared to non-consumers. So that is dramatic and a very, a relatively simpler thing to eliminate in somebody's diet. Secondly, there have been studies to show that fructose consumption is independently associated with fibrosis severity, so that's definitely something to hit home. And then ultra-processed foods and high saturated fats. Specifically, though, I want to focus on a few things, like obviously cakes, pastries, right? Burgers are more obvious to patients, but I have found that a lot of patients consider processed snack bars to be healthy, like some protein bars they think are healthy, they keep eating them. Some dressings that they're putting on salads, which they think is healthy, and then flavored yogurts, which also is typically marketed as a healthy alternative, do still contain a lot of processed components, right? So those are typically three things that I do mention in my visits to watch out for. Now, in terms of the types of diet, right? There's so many different types of diet out there, and it's true that the Mediterranean diet is the most guideline. In other words, it's the most society-based recommendation. So most societies recommend Mediterranean diet, but is it really the best diet? So yes, it does have the most kind of long-term evidence for cardiometabolic risk reduction and improved mortality in this cohort. But the reality is that low fat and low carb diets also have similar long-term benefits, right? We shouldn't downplay these other types of diets. In fact, there was a recent trial that was just published last week that did head-to-head low fat versus Mediterranean diet, and it actually showed no difference in reduction in mean CAP, LSM. Remember, these are liver stiffness measurements and weight in both of these groups, right? So it really, we don't need to blanket recommend Mediterranean diet to our patients, right? We can modify these things. In contrast, when it comes to very low carb ketogenic diets, that gets a little bit more dicey, in my opinion. I tend to avoid that for these patients unless I have a lot of dietitian support. And then time restricted eating has some mild to moderate evidence for reducing steatosis, but in my opinion is more helpful for reducing the caloric window and providing a calorie restriction rather than an overall diet specifically for MASLD. But how can we make the Mediterranean diet work for more people? And I think one of the family docs brought this up earlier, which I'm really glad he did. And this is actually a figure from their paper that actually, recommends for our South Asian, for some of our Southeast Asian, some African households, where could they incorporate some things that might not be the typical olive oil components, but might be more in line with their typical diets, right? And I think this is a great example. So incorporating more bok choy or more bulgur wheat, tofu instead of some of the typical recommendations here. Similarly, when it comes to affordable diet modifications, some of the things I want to highlight is frozen vegetables. So typically we look down on frozen vegetables, but the reality is they're really not so bad and they're much better and more affordable for a lot of our patients than, fresh vegetables, which are very hard to come by in a lot of communities. Canned beans and canned chickpeas and beans are not the enemy, but I do recommend to my patients that they rinse off the beans if they're canned to get rid of some of that sodium content before they consume them. When it comes to some practical tips for my patients, of course, I'm sure a lot of us are familiar with actual applications that you can use, like MyFitnessPal or Lose It. But what I like to recommend to my patients that a lot of them don't know and really appreciate is activity after meal, specifically a very heavy or a high carb meal. Even walking around their apartment for 5 to 10 minutes can really lower that postprandial glucose spike. And alternatively, if they're not very mobile, then even doing some calf raises at the dinner table after dinner can really help. Secondly, I always recommend a carbohydrate last food order. It's the opposite, unfortunately, of what most restaurants do, right? Like they bring out the bread and then you have your meal. Many studies, including my colleague Dr. Shukla at Cornell, has shown that eating the carbs last really improves the insulin resistance component and can lead to weight loss. And it's actually recommended by Obesity Society guidelines now. Of course, dietitians are an absolutely incredible resource, and we should definitely use them. But in my experience as an endocrinologist, and I'm sure in your experience as a primary care doctor, sometimes they're hard to come by, or the wait list is very long. So I do tend to recommend sometimes these trusted online platforms. I specifically like Palm Health. It has a lot of very well-trained, trusted dietitians, and they do accept insurance. It's not like an out-of-pocket fee. I also want to highlight that a lot of institutions and local community centers, they do offer free teaching kitchens or group telehealth classes that patients might benefit from. Some of my last tips, which I won't go through in depth, are swaps, right? Like seltzer for sugar sweetened beverages, 2 to 3 cups of black coffee a day, which has actually been shown to reduce the risk of advanced liver fibrosis in patients with MASLD. And then bulk-based meal prep like beans or soups, especially in the wintertime, are really great ways to get in that protein and that vegetable kind of component at the same time. But patients do want examples, right? Like sometimes it's too much, information overload, right? And so giving them a grocery list or giving them a recipe can also be very helpful. And in 2025, during World Liver Day, they actually came out with a very great, visually pleasing, and I think easy to understand recipe book. These are just some examples that I think really can benefit our patients with MASLD and MASH. I won't go into the weeds here with alcohol use, but I would be remiss to not mention it because there is a synergistic effect between alcohol consumption and metabolic dysfunction in terms of progression to fibrosis. So especially our patients that have at-risk MASH, F2 or greater fibrosis, they should actually be abstaining from alcohol use completely. Thankfully, there's been a little bit more of a push, in my opinion, at least in the US, towards like mocktails or making that more socially okay and push towards non-alcoholic wine and beer, which is also less caloric, to kind of recommend to your patients. And lastly, I just want to bring up the role and the potential utility for continuous glucose monitors. Obviously, as an endocrinologist, this is something I use very regularly and probably something that a lot of the PCPs on here do as well. But you have Freestyle, you have Dexcom, now you have some over-the-counter CGMs. And if they're not available to you or the patients can't get them covered, I really do encourage you to either reach out to the local endocrinologist or to the local sales reps because they are usually very, very happy to send you free samples to give to your patients. At least that's been my experience. And that biofeedback component is very real. So I can't tell you how many times my patients have been so happy to wear a sensor even for 2 weeks and notice the difference that the sushi rice makes on their diet versus the bulgur wheat, in that peak. Fatty Liver Alliance, just a shout out, they do a 30-day glucose challenge in July that you can always join or tell your patients to join. So, kind of my takeaway is that just in the same way that we prescribe medications, right, we should also be prescribing nutrition, even if it means actually physically handing our patients something that says, eat this, do this, right? It might seem silly, but it really works. And Dr. Sine has shown this to be the case with his really cool exercise prescription form, which he may bring up in just a few minutes. And if you want some practical tips or some videos, some creative recipes, I do recommend following Kaiwell Nutrition. They have a really wonderful platform specifically for MASLD and MASH recipes that are amazing in my opinion. You also have Liver Health MD, I think, who's based in Canada, obviously Fatty Liver, and then a shameless plug, I do some MASLD and MASH content on my platforms as well. Thank you so much for listening.